Hey everyone, welcome back to EMplify. I'm your host, Sam Ashu. Today's episode is a special one devoted to the topic of racism in medicine. Our country is grappling with racism and our individual parts in it. And we in the medical community are no strangers to racism. In fact, racism has some strong historical roots in the practice of medicine. And so today, I've invited Dr. Maurice Selby to join us to begin that conversation about racism and the part it plays in medicine today. Dr. Selby is a practicing emergency physician and host to Health in Harlem, a radio show that's been on the air for now over 14 years. And so I'm sure you'll enjoy hearing him speak about this topic as much as I enjoyed discussing it with him. Without any further ado, here's Dr. Selby.
Hi, my name is Maurice Selby, Maurice Donovan Selby, and I threw the middle name in there for all my friends out there, colleagues that always looked at that middle initial and saw it to be a mystery. Well, it's out there now, Maurice Donovan Selby. I am an assistant professor at the Emory University School of Medicine in the Department of Emergency Medicine, and actually just recently moved to Atlanta, Georgia from New York City. Lived in every borough of New York City, including Staten Island. Went to public school all the way through up until SUNY Downstate College of Medicine, actually, and then did my residency there in Kings County Hospital in emergency medicine. And also I'm the host of Health in Harlem, which airs on WHCR 90.3 FM every Thursday. And we actually recently developed a podcast to accompany our broadcast show with the recent developments with COVID-19, as we can't produce it in the studio now. So
awesome. So in addition to listening to this podcast, you can search your Apple Podcast app for Health in Harlem and start listening there as well. Thanks so much for agreeing to be with us today. I invited Maurice to join us specifically to talk about racism in medicine. As the country's been struggling with identifying racism, I've had more conversations with partners, friends in medicine, people I went to residency with, other people I've gone to medical school with about racism in general, but also specifically in medicine. And there has been a surprising lack of knowledge about the history of racism in medicine and almost a denial of the existence of racism in medicine currently. Mm-hmm. You know, some people operate with the idea or the notion that, well, there may have been some in the past, but we're not implicitly racist in our medical practice, therefore it must not exist. And when I speak to my partners or friends of color, whether they're physicians or even as patients, that's not the response or the experience that they're getting. And it's distinctly different from what the others are saying. And so today, my hope is to kind of shed some light on what the history of racism in medicine was, but also what it looks like today and what we can do to identify it and start to hopefully change that, especially that perspective that, some people might have that it doesn't even exist anymore.
I think you're on the money in that, there's this sort of belief that, or amongst some, and some, unfortunately, is a significant proportion of the medical community that this doesn't exist, or at least doesn't exist in the historical sense when we talk about racism in medicine. And really, that historical sense, has its roots in things like Niggerology, which for centuries, right, we're talking about starting in the 16th, 17th centuries at the height of the transatlantic slave trade, where essentially there was this sort of scientific inquiry to establish the inferiority of Black people. And therefore, through that inferiority, sort of rationalizing and legitimizing the destruction and exploitation of Black bodies. That's where this history lies. This sort of overt racist scientific, quote unquote, pursuit, which we now acknowledge as pseudoscience today, but some of the beliefs and misconceptions from that time persist today, and they've made their way from these individuals that wanted to perpetuate this hugely lucrative business. It's made its way from there through the medical establishment, and we're talking by way of our reputed journals, right? In the history of medicine, some of the biggest names in medicine, such as James Marion Sims, the father of American gynecology, and his beliefs that blacks had higher pain thresholds and therefore he can experiment on his slaves and perfect his gynecological procedures. That's where this history comes from. And while we don't see it everywhere around us, you can't just experiment. Like, thanks God for things like the IRBs, local IRBs, and sort of the ethics behind medical research that we have established today. Thank God for that stuff. But some of the subtle beliefs and misconceptions and even subconscious biases that we have, those things persist. And that is the problem, is that we can't see it on the surface. It's something that we really have to dig deep to acknowledge. And it's really something that we have to acknowledge in each and every one of ourselves.
When we talk about the history of racism in the past, we're talking about things like the beliefs that Black people would not feel or perceive pain in the same manner, that Black people could somehow endure excessive amounts of heat, work extra hours,
Yes.
not have to eat or drink as much, really anything that would support the practice of slavery as an excuse to continue to enslave Black people and justify that medically. So somehow that their physiology is different and therefore this is an acceptable practice.
Correct. That is correct.
And that, as time has gone on and some things in the practice of medicine have changed, like you mentioned the IRB, for example, that's the Institutional Review Board that is supposed to review the experimentation you're going to perform on a human being in the name of science and then approve it as being humane and acceptable. Those kinds of institutions were developed to try and combat that specifically and make sure that you don't have some kind of racist, unethical, inhumane treatment of human beings in your experimentation.
That's right.
But yet, despite that, we still have these pervasive viewpoints, right? So, for example, you and I were speaking before the start of the recording about non-compliance in patients.
That's correct.
And the perception that Black people might be non-compliant with medications or recommendations of their physician because they're just not interested in taking care of their health, or it's not a priority for them.
Yes. And that's part of that history, or at least what the remnants of that history. Right, these sort of beliefs and prejudices that we might harbor as clinicians. I'm saying, right, as we treat patients at the bedside, and rather than maybe digging deeper to see, right, what the real motivation behind this quote unquote non-compliance might be, rather than coming to the bedside sort of assuming that the patient might not only understand you, right, and be educated enough to engage you in a discussion about the care that they're receiving and where they want to go with that care and the direction of that care. We have maybe certain beliefs that we might sort of dismiss a patient's concerns right off the bat. We've already written them off as being a difficult patient, quote unquote, or a patient that might not be worthy of going through that more detailed investigation and really giving them the optimal care. And it's something that, like I said, is not that the motivation of the clinician is the problem. I think the vast majority of clinicians out there, right, we strive to do our very best for our patients. But at the same time, our Achilles heel is going to be these biases and beliefs that it's not our fault. We've been trained to think this way sometimes, and it's not even just through the history of medicine, but in terms of what messages we receive from all around us in society. That constant messaging that informs everything that we do in medicine, from public health measures down to medical education and the doctor-patient relationship.
We still see that kind of racially based practice of medicine even today. Two quick examples that come to mind are things even as simple as blood pressure management. You
Mm-hmm.
look up guidelines for management of hypertension, and it is right there in writing. What is the color of the patient's skin?
Mm-hmm.
Then you should pick this agent. If they're white or some other race, you should pick this agent, and if they're black, you should pick this as a starting agent, which seems odd. I mean, it sets the precedence for there being a racially
Appreciate
based difference,
difference. Mm-hmm.
and that's still pervasive today, even in medicine. But it kind of seems to almost legitimize the practice and say, hey, there are differences, and those differences can be based on something that we attribute to skin color, and therefore you should change your practice based on that.
Yes.
And that's it's strange, right? At least to me, it seems strange given our history and how far we've come that we still look at research like that and go, yeah, okay, there is somebody did a study and it turns out that based on your color of your skin, this is what we have.
And we run with it and believe it. And I think that really just points to sort of the pervasiveness of this problem, in that it starts at the highest levels and has really worked its way down to, like you said, in the delivery of care at the bedside. And really what it comes down to is addressing at every level, as we said, starting at the societal level and talking about changing legislation. So, for instance, the implementation of institutional review boards, right, starting at the highest levels, but also going down to the individual level and questioning guidelines like that, or questioning our rationale as we deliver care at the bedside. Are we making decisions based on this individual patient, or from what we believe based on what we've been told by society, or based on what we misconceptions that we might hold at heart? And really, when we look at examples of how this might play out, so for instance, in cases with children, and they come in with injuries, of different sorts, and I have a 4-year-old, so I know, like, these kids are gonna fall, they're going to do things, get into trouble, and come up with boo-boos, and they come to the ER. And when we have, and I've experienced this even in my training, where kids came in and the parents were able to give pretty good history, and things aligned in terms of the injury patterns and sort of what was relayed by the family. And yet we still ask that question was, oh, well, is this a, should we call ACS? Should we call, adult child services and get them involved in this case, or social work? When pretty much every indicator from the history and physical indicated that this was, an accidental trauma. And we would see in the same shift patients from different backgrounds, white patients, Asians, and that question really wouldn't come up. And it would be very similar circumstances, right? And so getting to at the root, like what was that motivation behind thinking that this might be a non-accidental trauma? And again, I think it goes to show that, yes, we all have that child's best interest in mind. I think when that decision was made, or at least to think about calling adult child services, we had that child's best interest in mind. But at the same time, when we look at what could happen, right, the fallout that could result from calling adult child services, the stress on that parent, the investigations that might take place, and ceasing of benefits, public aid benefits and stuff that might come with that, housing jeopardy of housing for these people, like all of these things that can sort of happen just because we had this implicit bias that no one really acknowledged. And that's what it probably stemmed from.
And even now, with the pandemic and COVID-19, we're finally starting to see some public reporting and collection of race data.
Yes.
And it, for me, it seems to be heading in that same general trend. We look at the mortality rates of people who are Black versus people who are from other races,
Hmm.
and we see the mortality rates are higher.
Yes.
And then we see unceasing opinions published about why that is without any good real data. Things
Yes.
like, well, Black people have more hypertension and diabetes, or Black people are more likely to be non-compliant, or
Yes.
Black people live in poorer neighborhoods and have less access to medical care and therefore have a higher rate of other diseases, and therefore that must be the cause for this discrepancy that we're seeing.
Yes. And while we can say that, and I think those things are very true, right? There's um, tons of data sort of backing that up. Those are facts, if you will. However, what is not acknowledged routinely, and this I think goes back to the beginning of our conversation, where you said that there are people that just didn't even acknowledge racism in medicine,
Mm.
and the where the racism in medicine really comes in is at the provider level, right? These are societal ills that, yes, led to the disparities that we see with hypertension and diabetes in Black and urban communities. There are issues, right, stemming from historical racism, from things like the Tuskegee syphilis study, or really going even further back than that, right? As far as Black people and some degrees of mistrust of the medical profession. But when we talk about the individual provider, there are some of these outcomes can't be just explained by those sort of societal um, level issues, but we talk about individual practice at the bedside. And so, for instance, the fact that women in New York City, for instance, Black women are 12 times more likely to suffer um, uh, death in maternity, right, than white patients in the city. And when we look at sort of the experiences of Black women and what they tell you, even my wife, we're currently expecting now, and some of the concerns she has, it actually happened with us where our sort of biases, and I'm saying that me, even as her husband, we didn't address her concerns at times. Sometimes we said, "Oh, your water didn't break. You just, you just might be peeing on yourself," and sort of dismissing those concerns. And we were on our way to discharge when actually my daughter was about to be born,
Wow.
and I remember being next to her, and she's very frustrated at that time, and wanted to be re-examined to really determine whether or not her membranes had ruptured. And me coming off an overnight shift and really was really wanting to go back home and get into bed, I was like, yeah, they're probably right. I mean, these are difficult exams to conduct. These are difficult things. I think we can go. And um, at first she was sort of being um, discounted as far as her concerns. And ultimately, when we checked again, we actually did rupture, and my daughter was going to be born. Now, who knows what might have happened, right? We'd gone home, her membranes are ruptured, and we come back later when we're at a higher risk for, things, infectious etiologies and prolonged rupture of membranes and stuff. We could have had much more difficulty and a worse outcome if we had just let it be the way it was on that initial assessment. And that's something that, while we can't, as I said before, I don't think this is something that we consciously do where we say, I'm just going to write this person off. But in terms of the implicit biases as far as educational level of our patients, their ability to understand our assessments and instructions, and even when patients advocate for themselves, right? Not being labeled a difficult patient, but a concerned patient that requires further counsel, and maybe they deserve, they want that reassessment. They have legitimate concerns for wanting that reassessment. That's where these issues really come into play. And these are things that are very hard to account for at the individual level, because, as we said, it's not something that's conscious. You are not consciously doing these things. You don't consciously want your patient to have a bad outcome. But at the same time, some of the misconceptions that we have, and they stem from, as we said, this sordid history that we're all involved in and affected by. That's where all of this comes from. And it really serves to account for some of the discrepancies that we see in terms of health disparities and outcomes between Blacks and white patients.
And when we think about, in that setting, trying to combat something that's not even on my mind overtly to try and change, that seems almost like an impossible task. But I think the first step is just recognition that this is existing in this relationship between me and the patient.
Yes.
At least acknowledging, okay, there's going to be these interactions where I'm just going to want to be dismissive of this patient, or I'm going to attribute something that I haven't actually investigated. I'm just going to say, oh, they're non-compliant. They're chronically non-compliant, and just dismiss it. So acknowledging the problem is step one. But then, for you and I standing there at the bedside with our patient, where do we go from there? Once I go, oh, well, okay, this is a non-compliant patient. Now what? That's the next challenge there, right? What do you think?
That is the next challenge. Once we've established sort of, okay, this is what, I'm presented in front of me, and now I need to uncover, right, what is in my thoughts as the provider. What am I thinking about this patient? How do I feel about this patient, what I've been told, and how am I going to acknowledge biases that I might have toward this individual? And how am I going to overcome those biases? That's really what it comes down to. And I think, as you said, one, acknowledging, right, that racism exists in medicine, not in the form that we saw it, decades and centuries ago, but in a more subtle and implicit fashion that is persistent and more difficult to deal with. But then at the individual level, dealing with the fact that we all have these biases. We all have them. In all of our interactions with patients, we come to the bedside with some amount of prejudice and bias that, as clinicians, we must acknowledge and deal with in order to provide optimal care. And it's something that is difficult, definitely requires more effort. And that effort, right, translates into digging deeper. When a patient is being difficult, there might be a reason why that patient is expressing themselves in a certain way. Maybe it might not be that interaction with you. It might be an interaction with another provider recently, why they're not following your instructions, or why they do not want to follow through with a diagnostic plan or a treatment plan. And really digging deeper to uncover that. That's the only way in which we can really deliver the best care possible.
It's so fascinating to me that this is still something that we have to combat on a daily level or on a daily basis. I recall last year looking through the fourth universal definition of myocardial infarction, something I'm sure you read on a daily basis.
Yes.
It's a compendium that the cardiologists put out annually, maybe less than annually, and it's just going through the different MI, so STEMI, non-STEMI, type 1, type 2, et cetera. And there was, at the very end of the article, just maybe like 2 or 3 lines that said, in patients with non-STEMI, there was a trend for higher mortality in patients of color, so Black patients and patients
Hmm.
of non-white races, that even when you accounted for all of their medical history, all of the care that they received, still could not be attributed to just their medical risk factors,
Hmm.
suggesting that there was a bias based on the color of their skin. And this
Yeah.
was like a little 2 sentence blurb at the end of this massive document. And it was actually the most striking part of the entire article as I read and said, wait, you just said that patients are
Right.
going to do worse when they have a non-ST elevation MI purely because they're Black
Black. Yep.
and for
And
no other risk factor, no other attributable cause.
nothing
It's
else can
just
account for it.
yeah, it's just the
What,
color of their skin, suggesting that there's bias still in medicine, and you buried it like at the very last 2 lines of this article. It's crazy.
and it's crazy. And the thing is, it can, why I think why it's so difficult to account for that, right? Why there's quote unquote no explanation is because we can't be in the heads of the providers um, of those studies, right? Those patients, those people in that sample, or wherever that data was obtained, and they made that statement. We can't be in the heads of those providers at the bedside, right? How urgent did they think those patients needed to be seen? Were they pulled from the waiting room because they had chest pain, or were they sort of written off as malingering? Were they that? Where was this a patient that had social issues, right? Stemming from societal racism, right? Which we know the economic disparities that are attributed to systemic racism in this country. And so this person comes in and, they're sort of disheveled and maybe even undomiciled. And that person doesn't come back right away because they have chest pain, and everybody thinks they just want to be in the emergency department for a bed and something to eat, right? Maybe that was the thinking of, and I'm not just talking about physicians, but the triage nurse. It could be the clerk, the registrar that's checking that patient in. This is at every level in the system. Everybody is implicated in this, including myself. That's as a Black man that treats Black patients, I operate with the same biases at times, and I have to step back and say, hey, you know what? I need to go a little bit deeper. Perfect example of this. And there was a woman that came in, an elderly female. This is at my old places at Kings County. Elderly female comes in, and she's very upset. And at one point, we're thinking maybe she's exhibiting some sort of delirium and symptoms of psychosis, because she's saying that she's been speaking to God, and her landlord has been infesting her apartment with bugs and trying to get her out of the apartment, right? And so he's deliberately infesting her apartment with bugs. He's like coming in and out of the apartment when she doesn't want this person there, and it's all all of these actions are directed at her, and she's been praying to God, speaking to God to deal with this issue. And at first, we're like, this is a patient. Maybe she's just has a psych history. We really didn't have much history on her. And so we're looking in the records to see if she had any previous psychiatric, visits in the psych ED. We're going back to the bedside and just trying to obtain more information. And lo and behold, we get our social workers involved. And finally, we uncover, and she had been there for a long time. And after we excluded, any sort of medical etiology for this, what we determined was that everything she was telling us was actually true. And
Really?
this is true. And what it was is that, right, we know this in New York City, the reality of gentrification and landlords that are intentionally slumlords trying to evict patients from their apartments. And this was not a woman that needed a psychiatric evaluation, right? This was a woman that needed a social worker at her side to help her keep her apartment. This was actually happening. So he wasn't deliberately infesting the apartment. He just refused to call in exterminators. He purposely, let the building essentially rot to get people out of their apartments. And she was praying to God to remain in her apartment. And this was a woman, she was of West Indian descent. And so there was some cultural issues. I'm African American. I was born here, raised here. My family, has roots down south. And so some of the things that she was telling us, we told it to some of our other colleagues. They're like, oh, yeah, of course. Like they were able to, and them being of West Indian descent, understand where she's coming from, how she's talking, how she's describing her interactions and talking, quote unquote, to God. She's praying, and she was trying to really seek aid and remain in her apartment. That's what really everything sort of came out to be. But again, we had to dig deeper, right? We had to put aside our biases and really get to the heart of the issue for this patient. And I mean, it took extra effort, but in the end, I think we were able to optimally serve her because we didn't commit her to an inpatient psychiatric facility. We were able to get her the services that she needed to remain in her apartment, or at least get her on that track.
One of the most striking cultural differences that I unfortunately see on a regular basis in my practice is in just the notification of death to a family. When I've had to have that conversation with families multiple times, and I hear from my partners and from other staff in the emergency department, we'll suddenly hear an uproar of yelling and wailing and just an outpour of grief and emotion. And people will just stop in the emergency department and look up and go, what's going on? What is it? What is all that noise all of a sudden? And then someone will say, oh, a patient just died, and they're notifying the family. And you can see just a mixture of facial expressions. You've got the people who are sympathetic. You've got the people who are kind of rolling their eyes and go, oh, here they go again. They're yelling and screaming and tearing up the waiting room, or they're being loud and boisterous and disturbing, with a complete kind of passing over of the fact that, the cultural differences we have, even just amongst Americans. Now, I'm not talking about people from other countries, kind of lead us to take that information in and to express it differently. When I'm sitting with a family who says nothing, and just you can see tears pouring down their eyes, and they're grieving, but they're not outwardly demonstrating anything else. And then the next person I tell is thrashing about and yelling and moaning and wailing. And I've had those discussions with people. They go, oh, that's just, another Black family reacting that way. It's so disturbing to the rest of the department, or it's so annoying to hear that, or it's going to scare other patients, and there's a lack of of understanding. Well, you put yourself in their shoes. We just had to tell them that their mother passed away, or their mother died. And yeah, there is a cultural difference in how we express that emotion. Some cultures will come out and be more outwardly vocal about it, and that's okay. They weren't harming anybody. They were just causing a perceived disruption, but the reaction was different. It was, oh, they sat there, they were tearful, they're crying, I can tell they're in pain. What can we do? Should we bring them back? Can they see their loved one? As opposed to the other scenario where it was like, wow, this is just, you're being disturbing to patients, you're yelling, you're screaming, you just need to go away.
Yeah.
And that difference in even just the cultural response to that moment of grief is so tied to race as well, but the response is completely different depending on who it is.
It is, and I think this also sort of goes back to what we were saying as far as when we look at these outcomes and we try to account for these things, right? The poor outcomes amongst African Americans, and really people from the African diaspora in general, and other marginalized people, when we look at our reactions to them, right? And we wonder why people are non-compliant or people don't trust our recommendations when they're skeptical of things, even with, so, for instance, COVID-19, right? And sort of the mistrust of the medical community and what's happening around us. We can't, to a certain extent, we can't fault those people because of our reactions to them. And part of those reactions, like you said, are rooted in our biases. Like, oh yeah, man, Black families. I'll tell you, just in terms of my practice in Kings County and being in Central Brooklyn, and just the myriad people from different backgrounds in the West Indies and how they grieve, right? And everybody is different, even within these collection of islands in the Caribbean. How they manifest grief and despair is very, very different, right? When we talk about from Haitians to Dominicans, right? Even being on the same island, they manifest their grief in very different ways. Some outwardly, some more inwardly. And we, as providers, are cognizant of that. And when you hear the wailing in the hallway, you kind of know who's out there, right? But at the same time, acknowledging our, oh boy, like you said, we roll our eyes like, oh man, that noise again. But at the same time, we have to really, at that point, make that effort, like you said, to say, well, as much as it's loud and might be unpleasant for everybody around, we have to go and provide care for that patient. We're not going to just shoot them out of the emergency department, but I'm going to talk to them just as I would any patient that has lost a family member about the next steps, right? About having them setting up memorial services and how they can contact our admissions department to sort of finalize those proceedings and get them to the mortician to be memorialized and be there to support them, right? From a standpoint of their grief, and providing things like tissues and stuff like that is what really we should be doing for everybody. And when we don't do it, this is where that comes from, that mistrust and non-compliance, quote unquote, and really just not being a fan of Western medicine. That's where all of this comes from. And so that adversarial relationship between doctors and the patients that they're treating that are underrepresented and marginalized.
Now, let's shift gears for 1 second. We've been talking about racism in the doctor-patient relationship from the standpoint of the patient, but it exists from the standpoint of the provider as well. So the physician, the nurse practitioner, the PA. I've spoken to people in those positions who have personally experienced racism as a medical provider, which was even more surprising for some of my colleagues who think, well, if they believe it doesn't exist between the doctor-patient relationship, they certainly don't think it's going to exist in amongst the providers. But they have, a couple of them anyway, have confided in me in regarding some of their own experiences with racism as a medical provider. And I'm always surprised by it. It always takes me kind of by surprise when I hear about it, because it's not something I personally experience. But I'm curious to hear if you've had those experiences and if you have any hesitance about telling people about them.
I can say that I've had those experiences throughout my entire career. I'm talking about going back as a high school student all the way to now. So, I remember walking into the guidance counselor's office as a student, and sort of as a high school student, walking into the guidance counselor's office and just seeking information on college, the admissions process, and really getting ready to start my applications. And the first thing that she hands to me is just the local sort of community colleges. At that time I was an honor student, involved in multiple sports, managing editor of the newspaper, and had my eyes set on a range of possibilities as far as college options. But she relegated me to what she thought was appropriate for me as a Black male. Haven't even, she hadn't even gone into my file to see what I had been doing up to that point in my high school career. We in college, actually. So as when I was initially getting my advisement during orientation, my guidance counselor, who ultimately, was ultimately one of my pre-medical counselors, when I had inquired about just some information about the, pre-medical courses and sort of getting on track to apply for medical school, or at least what it entailed, and in terms of getting ready, she refused to talk to me until I had done 2 semesters, right, to sort of, I guess, prove myself. Refused to give any advice in that regard. And I talked to some of my other colleagues, right, white, Asian, who had received that advisement at the same time during their initial enrollment into the college. And so it's something that still happens today. And in terms of, the microaggressions that persist even up to this point in my career, whether it is a patient that mistakes me for a nurse or a patient care technician, are also subtle, right? And people don't know that they're doing these things, but these microaggressions that can be detrimental in their constant bombardment of a person's psyche. We have literature showing how detrimental that can be to providers. And it's those nagging things, those little things that little insults or assaults, I would say, that can ultimately make you question yourself as a provider, right? Leading to things such as that imposter syndrome, which we know can affect all of us, but has perhaps even more effects on minorities. And there's literature sort of speaking to that as well. And so it's something that I've definitely experienced, and I know some of my colleagues that have experienced it as well.
And have you had any hesitancy in talking about it, or even, reporting some of these things? Or is there even, I guess I would say, is there even a point in that? But even just to kind of start the conversation about how it affects you personally, is there any kind of backlash or any encouragement to keep quiet about it? Have you ever experienced any of that?
So it's one, and I think it's something that, just as your colleague said, that they really didn't talk about it with anyone unless the person asks questions about it, right?
Yeah.
And what I think that stems from is kind of what we've been talking about, in that nobody wants to be a racist, or no one wants to sort of even be aligned with any characteristics or attributes that one would associate with racism, right? So if I were to call someone out for, looking at me, and maybe I got there at, normally, right, I get to my shifts like 6:50. Always like that. I'm a stickler for punctuality and just being on time. So if I get there 7:01 and somebody's like, "Oh, you're late," and I've seen other colleagues that come in, white, Asian, of other backgrounds, and no one says anything. And the one time, right, and usually it's like a legitimate reason why I was late, and somebody acknowledges that, I'm like, whoa, was that like an assault on me? Like, as a Black man, and this sort of stereotype of, I don't know if you ever heard of CP time, colored people time.
No.
Oh boy. Anyway, that's a whole, but it's a stereotype that's associated with Black people sort of never being on time. And so me, that, that's sort of a microaggression. And whether the person meant it or not, sometimes it's done jokingly, right? These are assaults or verbal assaults that we don't even know that we're doing these things sometimes when we do them. And it's not just, it happens to Black people, but it happens to everyone, right? The studious Asian medical student, right? And people sort of thinking that they don't have any other interests outside of medicine, or, some of the misconceptions that come with being of Asian descent, and some of the things that people might say, even with women, sort of the comments that are made to. And actually there was a an article I was reading where a surgery attending, sort of discouraged a female student from going into surgery, saying that, you won't have a family life if you do this. You won't be able to be there for your kids. And, this person that was interested in surgery now has to go on with that in her mind, right? Not just focusing on being an excellent surgeon or training to be an excellent surgeon, but now she has to sort of in her head grapple with the idea or the prospect that she might not be able to raise a family, right? And that person that made that comment had no no idea what this young lady was capable of. These are the things, and maybe that attending didn't mean anything by that. If anything, they thought that they were, advising this person in a supportive way by giving them this information or making that statement. But at the same time, this is an implicit bias that was in this person thinking that, oh, was that even the goal of this young lady? Who knows? Maybe she didn't even want to start a family, right? But this was the assumption of that attending to say something like that. And then this young lady has to go on and sort of work through that,
Yeah, and I've heard about these experiences of fellow emergency physicians in which seem like subtle ways, but actually things that I haven't personally experienced. For example, working in the same practice alongside a partner and having the Black physician get questioned about their care of a patient more often than the white physician for the same exact care in the same exact scenario. And it seems hypothetical, but I've actually spoken to some of my own partners and heard them complain, oh gosh, I had another conversation with so and so and it didn't go well. And I go, oh, that's strange. Why did it not go well? I've never actually had them really get into it with me. Maybe is it was it a hostile conversation? Was it something in the way that they said something, or what was going on? And they say, well, they were questioning my care, and so again, my initial inclination was, oh, okay. You're probably just taking this the wrong way. They questioned your care. It's okay. They're just trying to get more information. Maybe they're trying to assess what's going on. And he said, no, you don't understand. It wasn't just, did you get a CBC? Did you get a CT scan? It was, hey, why did you order this test? This was completely useless. And that has no bearing on why they're there in the emergency department. And you should know better. And then I just kind of stopped and went, wait, they actually said that? That came out of their mouth? And he said, yeah, that came out in the conversation, but this is like the 10th time he says this to me. And I say, I don't understand. Like that's never in the realm of my entire experience been my conversation with this physician. And I've been working beside you. I would trust you treating my family. I have no idea why their response was this way to you. It's not like your care is so far outside of any kind of standard. And then as I started to ask more about it, more and more and more occurrences started to come out, and I said, it's almost mind-boggling to not even know that this is out there and occurring. And the physician I was speaking to was reticent to report it or to say anything about it because his viewpoint was this was associated with race, and he wasn't going to start a big racism battle with this other physician. He was just going to take it and say, this is what it's like for me to practice here, and I just got to have thicker skin and put on my shield and armor before I go to work every day.
And in order to preserve relationships, like this is why, and that's exactly why it's so difficult, right? You don't want to call your colleague a racist. There are individuals that I've practiced with that have said things and done things where that I wanted to address, but in terms of preserving our working relationship and even friendship, I would really, in terms of how I thought they would take it, right, and telling them that they had these, that I think they were operating with certain biases and maybe needed to think about that more. Essentially, it could be taken as, oh, you're calling me a racist. And I've seen it even with patients where, and I've had similar experiences where, I counsel a patient on the diagnostic and treatise, and, that could sort of hamper or complicate our interactions going further. And plan after having seen them and and, gathered a good H&P and, present the plan with them. We're going forward and they have questions about certain aspects of the workup. I do my best in explaining why we're doing certain things or the utility in doing certain things, risks, benefits. And they're not quite on board, but then it has to be legitimized by my colleagues, right? Whether it's another, a consultant or even validated by the nurse, right? And then they understand, like after they get that second opinion, and it's usually a white person, that then the patient is on board and they're totally with the plan. And I put it in, probably went in even more detailed in explaining why these things need to happen. But they had to have that second opinion to legitimize my workups, and it's again, do I confront the patient about that? You can't do that, but these are the implicit biases that we have. I mean, one thing, there's times where I walk to the bedside and if I'm not confused for a nurse or a PCT, sometimes once it's established that I'm the doc taking care of them, they say, "Oh, so where'd you go to medical school?" Right? And I'd never see, they don't ask my colleagues that or consultants that come on after me that are taking care of them, but they ask me that question, and so I have to sort of legitimize myself, right? I have to tell them, "Oh, I went to the SUNY Downstate College of Medicine. Yes, it's a accredited medical school here in the United States." And yes, I did my training at, SUNY Downstate in Kings County, a very reputable program. Yeah, I'm highly qualified to take care of you now, and we can move on. But these are things that happen. And these microaggressions that, I think, like you said, your colleague and to a certain extent, I think myself, we put on this armor and just sort of are able to work and deliver care. And I would say quality care, regardless, but these things do weigh on you, right? And it's another thing that we don't really understand the effects, but over time, right, these are stressors. So things that you have to think about, which impact everything, even the clinician themselves, and in terms of burnout and progressing in one's career.
It is interesting for me that we spend time discussing these things, or maybe there's just more awareness of this when it comes to gender than when it comes to race. Because I've heard these same things from colleague emergency physicians who are women saying,
Yes.
they get mistaken for nurses or technicians, or they'll walk in and introduce themselves as physicians, and then later will still be thought of as the nurse, and the patient will say, "Well, I never actually saw the doctor."
That's right. Yeah.
And so the female physicians, even some I've spoken to, who said that they make a point of wearing their white coat and their badge just to stress the importance of, "No, I'm actually the physician taking care of you." And yet they still get those same kinds of questions. Where did you go to medical school? Where did you do your training? How long have you been here? Are you working with someone today? Kind of like, are you a student? So I'm surprised again to hear that there is a racial predominance to those kinds of questions as well.
That's right.
Yeah.
And even in terms of, when we look at that, these sort of microaggressions and, things like the minority tax, and when we look at the proportion of faculty, right, from underrepresented backgrounds in medicine, all of these things impact that, right? And so right now we only have about 7 to 8% of the faculty, right, in all of the medical college throughout the United States. Only 7 to 8% of the faculty are from underrepresented minority backgrounds. And when we try to think about increasing those numbers, one thing that's often not taken into account is dealing with these issues each and every day, right? And how they weigh on individuals that are trying to aspire to these various careers in academic medicine. All of these things, and really even at the bedside in terms of delivering care and being able to practice, right, with longevity into the future, like all of these things weigh in and can affect clinicians each and every day as we strive to take care of patients. And so it's something that is pervasive But again, I think what it really comes down to is really looking at ourselves as individuals. And I'm talking about practitioners especially, but even when it comes to society as a whole, each and every individual acknowledging these beliefs that we have, that we operate with each and every day. That's really what it's going to come down to in terms of addressing racism in our society, but especially in medicine, especially as professionals, right, that want to do better. That's the thing.
Mm-hmm.
Not everybody in society wants to change. Not everybody in society, wants to address racism and remove it from our society. But I think the majority, I would really want to say that every practitioner, nurses, physicians, patient care technicians, EMS personnel, everybody wants to deliver the best care to patients. And with that said, I think all of us want to deal with racism, but it really has to start with ourselves. And if we acknowledge that, one, that this exists and that we are all implicated in it, then we can actually move on to begin to actually tackle the problem, beginning with ourselves.
Well, that's said about as well as anyone could say it. I think the starting point is acknowledging it, which hopefully we take a step towards today with this podcast, and then from there are certainly lots of resources, information people can start to read and digest about the existence of racism in medicine, and then just taking it and trying to apply it in daily practice is a chore. It's not easy. It's definitely something that is going to take more effort, and it's not going to come naturally to a lot of us. But certainly, at least having that discussion with your partners. If you're out there listening to this podcast and you are a person of color or you work with people of color, I encourage you to have that discussion and not shy away from it, and just inquire about some of the experiences of your partners or share your own experiences. And hopefully you'll find a receptive audience willing to make that change. So Dr. Selby, I want to say thank you for taking the time.
My pleasure.
To be with us.
My pleasure.
I really, really appreciate you taking the time out of your busy schedule. Health in Harlem in the App Store for whatever device you've got. Go search for the podcast or listen to it on the radio. And hopefully this won't be the last time we talk, and we'll be able to nab some more time out of your busy schedule in the future.